Hi, I'm Doug Major. Welcome to this paper, The Cerebellar Contributions to Vision, Clinically Applying the New Neurologic Research with Advanced Eye Movement Techniques. Again, appreciate Jeff and everybody inviting me to be able to speak with you today. We're going to try to divide it into a triad, the cerebellum as a eye motor control and attention center. We'll try to investigate the different areas of clinical interest, the triads of the cerebellum as far as the anatomy, and then applying those neural mechanisms for better clinical outcomes. If you were like me, I really wasn't taught very much about the cerebellum, just the ABCs. It was a place of motor accuracy, balance, coordination, and the idea that it has its own homuncula. It was always fascinating when we did all those anatomy classes learning about the cranial nerves. They always cut off the cerebellum. You'd have those huge peduncles back here, but it was always on the back side. You know, we'd look at all the nerves and that weird nerve that comes from the back forward, but we'd always seem to forget the cerebellum. And of course, if you don't have a cerebellum, you can still live with these cerebellar agenesis issues. But we're finding now that the cerebellum is so important for what we do, especially what really compelled me was at the meeting of the Academy in Chicago where Tara Alvarez presented her research on what happens during convergence and how the most important area happens in the vermis. Well, what's the vermis? The oculomotor vermis is that middle section of the cerebellum, and it changes with vision therapy. Tara and Mitch have been doing some great research that have been so supportive as we have to start thinking more like neurologists. And also now most of us have a right eye. We can also see the differentiation, and usually any eye movement problem, the cerebellar is going to light up, and as Deanne Fitzgerald says, there's usually a bowing or missing or hypermetrics if there's a problem with the cerebellum. But who has influenced me most is this man, Dr. Jamshed Gajjar. Jam has just done such a great work, and I've had a privilege of working with him and his work on the cerebellum and particularly the predictive brain state. If you get a chance, we just put together a wonderful interview he was kind enough to do with me. It's the last month's the Vision Development and Rehab feature article. Put a lot of links in there. I hope you'd spend the time to investigate that. I think he'll be as excited about this as I am. And of course, Jam is just a remarkable person that started the Brain Trauma Foundation that sets all the guidelines for coma and now working on for concussion that includes vision therapy as a key part. And so his overview of his talk at the COVD was, it talks about the science of prediction, about predicting, and the cerebellum, of course, is so important. The metrics, the sensory motor variation, the key metrics, as well as the applications of not only concussion, but what we do with attention and optimization. And his, again, hypothesis, the brain is in the present, and the present's in the past, so we need to have some prediction. And this hard problem, it takes time for that neurology to work, and so he calculates about 2.5 seconds ahead we have to be predicting what's going to happen, and where does that prediction occur is going to be in the cerebellum. So we predict the future to interact with the present and experience the past. And he was kind enough to really, evaluate why we're here today with A.M. Skeffington's work about the where system and the what is it system, and the emergence of vision. Part of that emergence is a sort of a temporal portion, right? The when system, and that's in the cerebellum. And the human cerebellum contains 70 billion neurons, 4 times more than the neocortex. And it's particularly involved with that temporal organization that we're so much, we should be involved with. And while the neocortex is that crowning achievement, the cerebellum actually expanded 6 times faster than anticipation. So that cerebellum expansion freed up the neocortex from always being in the now. And it has so many cells for better prediction. So 75% of all brain cells are granule cells in the cerebellum for the timing. And as the brain grows by volume, the cerebellum grows the most, 88% the first year. And that has to do with interactions that occur. And we always talk just about myelinization, but this cerebellar granule cell growth is so fantastic. Starts with when you're born with just a little bit. In other words, it requires activation with real life and motor movements, eye movements working together to get that interaction. And then the granule cells just explode into action, calculating what's going to happen in the future. And as we talk about development, Jan does a great job of talking about what is play, and that it has to do with these predictable interactants and working on timing and synchronizing movement to the point of actually developing of ourself. And so because we can predict our own movement and we get a sensory feedback that who we are, that actually is part of the reason who produces our self, that percept. As I've done this today, I've been able to pull a lot of different slides from a lot of different people. This was done at the brain mapping. Some really interesting concept that the cerebellar connections are found for the dorsal visual stream, okay, the where is it system that we work so hard on, and no functional link between the cerebellum and the what is it system, the primary visual cortex. And isn't that what we do? We don't, we work on the where is it system and let our colleagues work on the what is it system, which is better 1 or 2 system. And this is really a cross-section of the work of this man, David Z. and Shamesh. They did a wonderful summary here a couple years ago, and he talks, I suggest you get this article. The cerebellum works as a network hub for optimizing eye movements through its mutual connections with the brainstem and beyond. The 3 key areas of the cerebellum of interest are the flocculus, paraflocculus, we call it the tonsil concept or complex for high frequency input, the nodulus, uvula, low frequency, and then the dorsal vermis, as well as the vestigial nucleus, FOR, for saccades. So he said there's no absolute compartmentalization, but he does a great job talking about the framework. And I'm going to suggest that you look at this article and how these three areas interact, but it's a few key points. Maintaining accuracy and precision calibration of the motor performance shows a robust adaptive capacity. And this is the interesting point. Unless you see a patient within seconds of onset of neurological insult, any abnormalities will be not only immediate damage, but an attempt for the cerebellum to repair the problem. In other words, a cerebellar eye sign just for diagnosis is one thing. We'll try to turn that and use these ideas for therapeutic adventures that we have. Some of the take-home messages that he said, really, it's steroids or the cerebellum is like steroid or plasticity on steroids, and eye movements, abnormalities are easy to observe and clinically easy to measure, quantify, making them an excellent marker for assessing diseases involved in the cerebellum, and in so doing, an excellent location for us to do our enhancement of function and also repairing function. This is sort of an overview of the 3 main areas. And again, obviously this is overwhelming. We're going to, the rest of the lecture, we'll be trying to ferret this down to how we can get it into our practice. And I really appreciate the efforts of functional neurologist Cedric and Jason for Focus Builders. If you get a chance, you should, again, look at their information. I appreciate particularly Jason spending personal time with me and sending me to some of these main articles. He spends a lot of time investigating this and applications. So I'm not a kid anymore, so I love the triads to understand things. So when we think of the semicircular canals, we think of the triads of the, yes, 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 the pitch, no, 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 y'all, ear to ear roll. The three movements of the semicircular canals, all associated with the neck. And then oftentimes we forget the movements of the otolith system and this bob up and down. Bob, think of Bob Pepper. We did a whole talk on Bob Pepper's the saccule stimulator with all the trampoline work that he did. Weave side to side if you're a boxer or a wrestler, lunge back and forth. These are the systems of the body that the otolith system, again, is connected with. And then I'm going to suggest that in the perceptual world, we have this triad of mapping, the superior colliculus for the visual mapping. It's this directionality and that really tunes up our eye movements. Inferior colliculus, the oral or the listening and anti-gravity system. And then below there is this huge area that we call the cerebellum that's going to take all those inputs and calculate the timeline and predictive future as well as corrections. To make this a little easier today, I want to maybe embody this. Get your tongue in here. If you can feel right in the middle of the top of your mouth, is there like a vermis, a worm? I'm going to call that the hard palate. We're going to call that the vermis, okay? And if you go back and you can see the anatomist did this for us already. Got a little punching back there. Move back and forth. That's the uvula. And if you put your tongue really far back and you haven't had a doctor take them out, I can still feel my tonsils back there, especially if they get irritated. So there's the three areas. So we'll try to maybe embody that as we go through today. So feel the hard palate. And we're going to think about the FOR, the vestibular oculomotor region. Think of the center, the vermis, the oculomotor vermis right down the center. Feel your tonsils, flocculus, paraflocculus, and the uvula, the nodulus and the uvula. These areas that are represented, so important parts of our eye movement part of the contribution for eye movements that we're so interested in. And again, I got to recognize this man, Eric Cobb, as well as his associate doctor, or Michael Golden, and the application that they put to these different cerebellar issues, and so, or cerebellar places that we can, enhance our neurology. So I'm going to go ahead and give you a little pretest, or this is just give you a feel of the depth of how these functional neurologists, and particularly Dr. Cobb's group, trains his athletic trainers. But here's an interesting question. These were difficult for me. Maybe you're smarter than me. Your patient is complaining of a muscular strain around his eyes while performing smooth pursuits diagonally down and to the left. So you decide to activate the associated ocular muscles with a reflexive eye movement instead of a voluntary one, VOR. Which of the following therapy would best accomplish this goal? Okay, an angular VOR drill with the patient's right posterior semicircular canal, an angular VOR drill for the patient's right horizontal semicircular canal, a VOR cancellation drill for the patient's left posterior semicircular canal, a gaze fixation drill while the patient's eyes are looking diagonally down and left. Could be more than one on this, by the way. We don't have time to go through this now. I hope you get a chance to go back. But here's a cheat sheet if you if you have a chance to go back. Here's question number 2. The vestibulocular reflex from the right anterior semicircular canal would best excite which of the following extraocular muscles? We're going the opposite direction now. Left lateral rectus, right medial rectus, right superior rectus, left inferior oblique, left inferior rectus, right superior oblique. Could be more than one, right? So we have the left LART plane, the right RALP plane. These were not taught to me going to school, and they're so important. Number 3, which of the following directions of gaze fixation would be most stimulating for the right half of the cerebellum? Eyes diagonally down to the left, eyes up, eyes diagonally down to the right, eyes left. Eyes up and to the left, excuse me. Little cheat sheet over here. After observing a patient that's walking with his left shoulder and left hip internally rotated, you decide to do some motor stimulation stacking with oculomotor input to provide corrective activation for this neurological gait pattern. Which of the following combinations would be most stimulating for the brain structure of interest? Now, I'll help you a little bit. Think of Parkinsonism as the ultimate poor, cerebellar condition. When you have a left shoulder and a left hip internally rotated, that means that the left cerebellum is not functioning well. So what would we do to fix this? Complex nonlinear body movements on her left side while fixating on a target with eyes left position. Complex nonlinear body movements on her left side while fixating on visual target in a eyes right position. Complex nonlinear body movements on her right side while fixating on a target in the eyes in the left position. Simple uniplanar body movements on her left side while fixating on a visual target in an eye's right position. Cerebellar activities are stimulated by complex nonlinear movements. A little other hint. Okay, so you get an idea of the range of sophistication that our friends that are applying this are doing, and I feel a little behind myself. So let's look at some of the ocular motor reflexes we know. When you bring your eyes up, that facilitates extension. When you bring your eyes down, facilitates flexion. Eyes to the right facilitates right rotation, right extension, left flexion, and of course left rotation, left extension, right flexion. And that really has to do with the way our cranial nerves are stacked and how they work. You've got the majority of them, again, they're divided, I think, for this reason, are for flexion. And particularly the trochlear comes down, and you have to look, you're looking down, and so that's in and flexing down, whereas the abductions and the cerebellum is out and up. We talk about proximity with people and about where we keep our attention. It's fascinating how well these systems are interacting and how we do, how things work. And so let's talk directly of some of these contributions of the three main areas that we talked about. So the cerebellum is intimately involved in real-time, immediate modulation of gaze shifting, gaze stabilization, as well as long-term calibration and adaptation of those skills. And we've talked about this before. And the cool thing about the cerebellum is it's so easy to teach, or so easy to assess. And so we do this all the time when we do our balance activities. It's really it's cerebellar. Think of all the things the police officer does on the side of the road for after a DUI. It's because the cerebellum is so affected. So again, Romberg's with perturbation, gait, finger to nose, tapping, rapping, pronation. I won't spend time on this. We should all be doing some cerebellar testing, or at least recognize what we're already doing as cerebellar testing. And so let's look at the contributions again. So let's feel your hard palate. Put your tongue up there. That's to activate acceleration and final deceleration of smooth pursuits. And because of that, because it's associated with acceleration, deceleration, it's also associated with accurate saccades. So really the FOR and the vermis, and again, we've talked now about the stimulation of convergence and how that has to do with the acceleration. When you think about that, maybe we should be working on, when we're doing, and we do this, most people are already intuit this, the acceleration and deacceleration of doing convergence activities on the Brock string. Okay, feel your tonsils back there, flocculus and paraflocculus. That's really essential for that eccentric gaze fixation. And this is something I think that I spent a little bit of time on. When you go past 10 degrees, essentially what you're doing, if you're looking off to the side, is you're your brain is saying move the neck. So you're actually canceling out the neck motion to hold that gaze. And that takes a tremendous amount of work to hold it there. And again, as we'll talk about location and directionality, there's some really cool things we can do with this if we start using gaze. We're talking about 30 seconds to stimulate certain areas if we really want to get some results with our vision therapy. And that significant role of the pursuit maintenance. And so that would be on the back, watching the Marsden ball just go, more than the start and stopping. So we sort of intuited this already, right? We do a lot of activities of just maintenance. So when you get that child on their back and they're working their way up to balance, maybe we make sure that we're doing balance activities right at the same time, which we usually do on one foot or a Romberg state. And then remember, it also is associated with the angular and rotational VOR. We'll talk about that in a second. Then the uvula is more about the linear translation. See, that's more of the otolith VOR and the velocity storage mechanism. And the cool thing is that these are directionality specific, meaning we can go ahead and concentrate on one direction if that's the side that's having more problems, or use, again, at least be aware of that it's a difference between the two sides neurologically. And so the FOR, so think of that, your palate there, discharges strongly, initiating pursuits and accelerations in the transverse or downward direction, and activates and deactivates towards the upward, terminating in deceleration in the upward direction. So it's activating down and decelerating up. Can we use that in our therapies? Absolutely. And then the folliculus, we got those horizontal pursuits to maintain those fixations and pursuits, and they're most sensitive to maintaining a diagonal downward pursuits and fixations. So maybe we need to be looking down and seeing the results. And then there's some interesting connections with the torsional that we'll talk about. So just to simplify of all these things, the FOR, think of your upward palate, speeds up one eye movement going in the opposite side and slows down the eye movement coming towards it. And so this picture is a great job from Z Health. How it accelerates down, decelerates up. And we know this, isn't it easier? So this is like, when we should be making sure that when we do our convergence, that we make sure we use both directions, and maybe we need to accelerate and decelerate as part of our therapies to be neurologically correct. And this is another, again, example through Focus Builder, how as we move up and down, and particularly our saccades with the FOR, how we can go ahead and stimulate one side of the brain or the other. And with the vertical, we can actually get both sides of the cerebellum and the pons, or both sides of the cerebellum and the the frontal lobe activated. And again, you notice how the vertical also isolates it and just uses the metacephalon. Okay, so maybe just talk about this neurologically. It's sort of fascinating that I wasn't taught that the huge amount of neuroenergy that goes between our ears and our eyes, probably 1 million times per second firing rates, that each side is trying to push your eyes in one direction or the other. And of note, again, most of the time it's equal, so our eyes stay the same. But as we look straight ahead, that huge amounts of firing is keeping our eyes stable. But as we stimulate one of our semicircular canals, the left canal, all of a sudden the misbalance is there, and that's why we get the VOR and immediate correction back the other way. And same is true here. Immediate misbalance, go the other way. And then we can just do a little VOR work, no, and really do some great stimulation there. So to go ahead and put this in maybe in simplifications, if I want to stimulate my left cerebellum, I'm going to look to the right. So go back and forth. So we want to uprate patterns for smooth pursuit eye muscles. And if you want to get both sides of the cerebellum involved, again, the up and down saccades work so well. Let's talk a little bit about the tonsil. Put your tongue back there and feel the tonsil if you'd like to. And the main function of the tonsil is to provide that inhibitory influence of the two vestibular nucleus and the two canals. So for fixation and smooth pursuit, the flocculus and parathocculus, the tonsils help the eyes move in the opposite direction of the horizontal and anterior canals. And so let's talk about fixation. Fixation, I don't think we take enough time looking at this. We need to really hold fixation off to the side is a tremendously powerful neurological tool. And a lot of times we just forget about it, or we move too fast. We just listen to a wonderful, talk and session on fixation with Jack Richmond. He really changed the way I looked at things. If you get a chance, you should really look at this, and you'll notice Jack moved over to, of course, it has to do with the cerebellum. He's done all this work on DUI and how eye movements are associated with states of vigilance and attention, and how that relates to everything. Would suggest you might again relook at Jack's work. I had a great conversation with him recently, and boy, fixations are where we need to start. So let's talk about this for the tonsils, again, the flocculus. So as we look up, back and forth, that's going to, again, affect that just like looking down to the others. And then this interesting, this torsional portion where you look way to your right and down, or way to your left or down, actually affects also is under this control. And so, again, torsional type of eye movements as we move, again, can also be stimulated by concentrating on our tonsil. So let's look at this again with both eyes. We go ahead and get the eyes to smooth pursuit now to the right, and see then our neck wants to move, and so there actually has to be a inhibitory type of thing to hold our eyes to gaze right, or same thing to gaze left. Our head wants to turn, we have to inhibit and hold our eyes. Some of the things we can do for better gaze control is a Troxler effect, just looking at this till the dots disappear, forcing our eyes to focus that 30 seconds. Or use Randot stereo and move it to extreme gaze and hold. Just so many ideas. Again, we need to start using eccentric fixation as a exploration of upregulating these systems. And the cool thing is this automatic, almost immediate correctional learning prediction takes place with these movements. Really exciting that in the Purkinje area, this learning site, huge number of neuroactivity. So maybe let's look at some diagonal muscle movements. So we go ahead and smooth pursuit down, and it requires that if we're looking to our left, the right flocculus has to inhibit to keep our eyes down there, or they would just zip right back up. And same thing, smooth pursuit to left. The systems have to work to maintain that. But so this diagonal direction is extremely powerful, and what Carrick talks about is Dr. Carrick, founder of functional neurology, is a collicular mapping activity. And I would say it was obviously collicular, that's what the mesencephalon, but it also is associated very closely with the cerebellum as you saccade in one direction and pursue down the other. And that's why you see that in the right eye training mode, that you have saccades up and down. It's also a part of focus builder. So again, very powerful tools to stimulate this type of cross stimulation and again establishing a powerful collicular map. Won't get a chance to go through all these things here. You're welcome to take a picture or look at it. Just remember, again, you get an idea. This is what we do. This is how we work. So associated with any visual therapy activity. And just again, remind you, the vestibular system is this valuable portal to get into the states that favor neuroplasticity, because that's what we do. We're trying to change, unwanted patterns, and it just has been proven as one of the most effective ways to drive neuroplasticity. And let's go back full circle. The eye movement tasks require prediction, and again, the head still things that we do, and then the eye movement things, and we should be doing both. And that measures prediction, and you keep that eye on the fovea. Of course, in Dr. Jahar's background, where has damage occurred during brain injury? It's right at those, superior peduncles that we were talking about, that we cut off when we study it, and that's the most important area of white mash or axonal shearing. So, just to finish up, the nice thing about the Stanford work of iSync is that there's really some really good measures now, reproducible measures of timing, spatial, and phase errors that are so important as we do predictive movements like a pursuit. And now we have the ways of finding in direct measure the difference between fatigue and injury, because sometimes it's hard to ferret that out. And of course, during saccades metrics, I can pull this. And so we've all, when we look at timing and a normal timing, how well a normal cerebellum can predict where things are in the future. And then, of course, when we have an injury, we have that jumping ahead. So really very powerful, metrical, evidence of Dr. Jam's hypothesis. And not only in pursuits where you talk about, jumping ahead with variability, but also the metrics of saccades now with precision and accuracy, and the VOR and VOR cancellation and NPC now. We can measure precision and accuracy in a very good degree. Tremendous amount of work that can be done now because we have this very good objective test. So thanks for your help. Any questions?